Good afternoon, everyone. The next item of business is portfolio questions on health and sport. I will try my best to get as many members in to contribute as possible. If a member wishes to request a supplementary question, please indicate in the chat function by entering the letter R during the relevant question. And question number 1 is Michelle Ballantyne.
Thank you, Presiding Officer. To ask the Scottish Government on what scientific evidence regarding a threat to public health the Health Secretary and the First Minister have based the decision to continue much of the lockdown measures.
Jean Freeman.
So, to judge whether and when restrictions can be eased, we consider a range of evidence on the progress of the pandemic in Scotland, including what we know about the reproduction rate of the virus and data on the number of infectious cases. The current position is that R is currently estimated to be between 0.7 and 1 for COVID-19 in Scotland and has been at that level for the last 4 weeks. The epidemiological model estimates the number of infectious people in Scotland on the 22nd of May to be around 19,000. This is the third week in a row that there has been a decline in this number and a sustained decline of more than 3 weeks for all supplementary health measures, which include new COVID cases, hospital admissions, ICU admissions and deaths. So that's the basis on which we go forward. It is set out in our framework for decision making, the route map through and out of the crisis. And today at 12:30 on the review date of the lockdown measures, the First Minister announced a number of easing elements to those, including elements which affect the economy, alongside the continuation of the stay-at-home message.
Michelle Ballantyne.
Thank you for that answer. The economy clearly needs lockdown to end and businesses to be able to get back to work. The First Minister and the Cabinet Secretary have now said that test and trace system is going to be the heart of being able to move forward. But we now know that the COVID cases began in Scotland during the Nike conference, where there seems there was a failure to trace those who had been in contact with participants. So can I ask, why did the tracing process not work then? What lessons has Health Protection Scotland learned from the failure of tracing in that case? And what steps has Public Health Scotland taken to correct the failings in February of March for that pilot tracing exercise? And can we now be assured that as we go back to work, there are enough tracers in place to make sure the economy doesn't end up having to close back down again?
Jean Freeman.
So I think what the economy needs, as indeed the business communities have told us, is for lockdown to end safely and for businesses to be given time to prepare, knowing that they can put in place the necessary public health measures in order to conduct their business safely, both for their customers and their employees. And that is precisely the road we're on and the road that we set out in that route map. It isn't accurate to say that transmission in Scotland started at the Nike conference. There was a case reported before that conference. And I don't believe it is either accurate or fair to our Public Health and Health Protection Scotland professionals who have considerably more expertise than I do. I can't comment for Ms Ballantyne herself, but considerably more expertise and experience in this area than I do, in order to make the judgments that they make on a tried and tested system in Scotland for very many years. Tracing, as members will know, contact tracing, test and contact tracing only works when transmission levels are low. That is why it is critical now, with transmission levels from the number I've just given you, indicating a decline over a steady period, a steady decline over a period. Transmission levels are low. That allows us then to ease those lockdown measures, but at the same time have test and protect in order to continue to manage and suppress the virus, which of course hasn't gone away.
Question number 2, Jackie Bailey.
Thank you, Presiding Officer. To ask the Scottish Government whether it will provide testing facilities in the areas with the highest incidence of COVID-19.
Jean Freeman.
This is a really important question, if I may say so. As Ms Bailey knows, testing in Scotland is provided through two routes, and this will continue. Those NHS-controlled routes, which is our NHS board laboratories, the academic partners that we have engaged with, and the Scottish Blood Transfusion Service. And the second route is through the UK Government Four Nation programme, which is the drive-through centres and the mobile units. And that those tests taken there go to the Lighthouse Lab. We are looking very carefully at the moment at how we can introduce closer to home testing for individuals as part of Test and Protect, and I hope to be able to make those decisions clear in the coming days. That includes looking at the use of our, for example, our COVID assessment hubs, which we set up in order to provide a safe primary care route, leaving GP practices COVID-free as best as we could, as well as looking at testing at home. That's different from the UK government's home testing kit, which still has a very slow turnaround. And Test and Protect rests a lot on the speed with which you can turn around those test results. Testing at home is looking at how we can use healthcare professionals to test people in their own houses.
Can I
Jackie Bailey.
thank you. Can I thank the Cabinet Secretary for that very helpful response? She will of course be aware that Western Berkshire has the second highest incidence by head of population of deaths from COVID-19. Yet health and social care staff and indeed local residents have to travel out with the area to quite substantial distance in order to get tested. Indeed, I have one constituent who was referred from Dumbarton to Dunoon, which is just incredible. So will the Cabinet Secretary ensure that there are local testing facilities, particularly in Western Berkshire?
Jean Freeman.
So I suspect the particular instance you gave us there, Ms Bailey, was someone who had booked a test through the UK government portal, and they would be referring people to the drive-throughs or to the mobile testing units. Those mobile testing units are now in the control of the Scottish Government, so we can move them in a way that makes most sense. They are, of course, as you know, staffed by the Army, so if the individual isn't going to take the swab sample themselves, and that isn't always straightforward, then we need to make sure we have clinical teams there as well. But we will go further than that, and one of the areas that I am looking at is a map of Scotland on which we overlay where all the drive-throughs are, where we can move the mobile units, but also where our COVID assessment hubs are, and then make sure that in addition to that, we can introduce, even if it is in a staged way, additional places where people can be tested, focusing on those areas, either, as you say, where they've had a higher incidence of COVID than others, or where there are particular geographical challenges to individuals driving. I'm thinking of remote and rural, and we do not want them to use public transport. So we're looking at all of that, and I'd hope to be able in the coming weeks to be able to set all of that out for members.
Quick supplementaries and answers, please, from Beatrice Wishart and then Stuart McMillan. Beatrice Wishart.
Officer, as we move to Test and Protect, the demand for tests will inevitably rise significantly, but the islands face unique hurdles when it comes to accessing testing, and local capacity has to be available. Can the Cabinet Secretary provide an update on how local capacity will be increased in island communities to meet this demand? And last week, the First Minister said that it will be important to publish testing data. Can the Cabinet Secretary provide an update on that?
Jean Freeman.
So on the last part of the member's question, we are currently working through what data and with what frequency we will publish on Test and Protect and how that is operating. It will include, for example, the number of index cases, the speed of test results, the number of contacts that follow from that, and so on. On the question of the islands, I know that there has been an agreement and arrangements reached in order to use satellite sites on the islands and ensure that the necessary chemicals and testing kits are there on the island so that they can undertake that. I will send the member details of that if that would be helpful, in fact, to all our members on the island communities. And in addition, of course, every board area, so including the islands, have their own pool of contact tracers.
Quickly, please, Stuart McMillan.
Thank you, Presiding Officer. A new mobile army unit was opened in Greenock last Friday, and I've been informed that only 8 people used the unit yesterday. Does the Cabinet Secretary agree that these units should sensibly move around constituencies to actually help both older households but also households without a vehicle?
Jean Freeman.
So the reason why I expect that there was such a few number of people there is because at the moment, or rather up until this morning, people were testing was demand-led, if you like, through that UK government portal and therefore to the mobile units. So if people didn't fit the definition at that point, then they weren't able to access testing. From this morning, Test and Protect changes the message very specifically. And what we say is, if you have any of the symptoms at all of coronavirus, please don't wait to see if you feel a bit better tomorrow. Please isolate at home and either use the NHS 24 free phone number or go on to NHS Inform website and book a test now. That means then that the testing capacity will be greater, the use of that will be greater, and it frees up the mobile units, as I said, for us to make more effective use of them. Perhaps in the way Mr. McMillan describes, perhaps in order to ensure that we maximise our testing speed in care homes, perhaps in order to ensure that they cover areas of particular deprivation or incidence of COVID. And all of that logistical exercise will get worked through as we see the data emerge of where people are booking that test. We will know that in real time and we'll be able to respond accordingly.
Right. And I say to members, we'll have to speed up a wee bit, so can we have single questions from people rather than multiple questions in one slot? Question number 3, Tom Mason.
Thank you, Presiding Officer. To ask the Scottish Government what proportion of care homes in NHS Grampian area have reported cases of COVID-19.
Jean Freeman.
Between the 14th of March and the 21st of May, 54% of care homes for adults in NHS Grampian had notified the Care Inspectorate of at least one suspected case of COVID-19.
Tom Mason.
I thank the Cabinet Secretary for that answer. NHS Grampian is one of the many health boards that have been supporting care homes with community response teams, so I have a few questions about their procedures. Firstly, how many have been deployed to help alleviate pressures on care homes? Have they been given access to routine testing in the same way as care home staff? And will the Scottish Government commit to national parity of testing between care home staff and these response teams, as well as expanding provision to all who provide care in our communities?
Can I say at this point that I would expect that members would listen to me. I know it's difficult, Cabinet Secretary, but if you could be quick with this answer.
So in terms of the detail parts of your question, Mr. Mason, I clearly don't have that information to hand, but I will secure that and send it to you. The last part of your question, which I think by response teams you will mean NHS staff from NHS Grampians assisting care homes as the Highland is doing and others. We are currently considering waiting on the basis of the clinical advice that I will receive from the CMO and from his scientific advisory group and from the Chief Nursing Officer, clinical and scientific advice on the use of testing in healthcare settings for healthcare staff in order to prevent the introduction of the virus in those instances, whether that should be blanket testing, whether it should be focused in particular settings for particular reasons, bearing in mind that we will be testing people who do not have symptoms, and therefore negative tests need to be repeated at least every 7 days. Once I have that advice and have taken a decision on it, I will of course make sure members are aware.
Question number 4, Mark Griffin.
Thank you, Presiding Officer. To ask the Scottish Government what assessment it has made of the long-term health impacts of suspending non-emergency NHS services and procedures because of the COVID-19 outbreak.
Jean Freeman.
So can I say this is a really important issue, and I'm very conscious of it. We were clear at the outset that we expected and knew that in order to protect against the largest harm, there would be other impacts that were harmful, not least in health. We knew, for example, in March that A&E attendances were at 40% of the pre-COVID level. In April, unscheduled care was at 27%, planned admissions at 33%. We began the NHS's Open campaign on the 24th of April, and since that time, those numbers have gone up. A&E to 59%, emergency admissions 72%, urgent suspicion of cancer referrals from 28% to 61%. So we've seen the emergence of closer to pre-COVID levels for those important healthcare needs. But part of what we are undertaking now as we look to remobilise our health service, we need to protect a capacity to deal with the virus. It has not gone away, and it may increase depending on levels of compliance with the easing of the lockdown measures. But at the same time, we need to take clear clinical guidance on which other areas that were paused that we can restart, bearing in mind there are other dependencies in that, not least transport and the use of laboratories. All of that, the framework of how we will make those decisions will be debated in Parliament. It will be published in the next couple of days, debated in Parliament on Tuesday, and as we make the decisions going forward, then members will be advised, and we may well return to that in committee or in chamber at some point.
Mark Griffin.
Thank the Cabinet Secretary for that answer. I've got a constituent with prostate cancer who's had their surgery indefinitely postponed, a hemochromatosis patient with venesection appointments indefinitely postponed, cataract patient with surgery indefinitely postponed, and another with hearing loss, which has been exacerbated by ENT appointments, being indefinitely postponed. And the reason for all that, as the Cabinet Secretary says, is that so that the NHS isn't overwhelmed by COVID-19. But can the Cabinet Secretary say what work has been done to assess the danger of the NHS being overwhelmed by missed routine appointments becoming emergencies, and what's in place to support burnt out staff, and possibly give an indication to my constituents of when they might expect those services to resume?
Jean Freeman.
Well, I regret to say on the latter at this point, I can't give an indication to your constituents, Mr Griffin, or anybody else's, including my own, about when those procedures may resume. Of course, all of those procedures that you have described, none of which sounded elective, perhaps the cataract, with the exception of the cataract case, none of the others were elective procedures, so they will be clinical decisions taken by the individual's clinical team, balancing the risk of postponement against the risk of going ahead whilst the virus was so prevalent in the community. We said that whilst we postponed and delayed other areas of healthcare, that the NHS remained open for emergency, for urgent care, for maternity. So the decisions where it was non-elective work will have been clinical decisions, and of course that's not for me to take clinical decisions to restart. But we are very mindful of all of this, both the harms and the impact of delays, including on elective work for our population, and will work hard now, that work is underway, to begin to plan how we safely restart those areas of the health service.
Can I say to members, I'm only going to be able to take one more question here, which is unfortunate, for Emma Harper and John Mason. But can I also say that the questioning and answers has been very long. There have been multiple questions within one slot. It's difficult to interrupt people when we're doing remote. And could I say to members, think on this before they come back to the virtual session. Question number 5, David Stewart.
Thank you, Presiding Officer. To ask the Scottish Government what research is done regarding the correlation between deaths with COVID-19 and patients with diabetes.
Joe Fitzpatrick.
Thank the member for the question. We know that this is a really worrying time for people living with diabetes. Their safety and the continued provision of care and treatment remains a priority for the Scottish Government and NHS Scotland. Analytical partners across the Scottish Government, National Records of Scotland, Public Health Scotland and the NHS are all working together to consider how we can better understand the impact of COVID-19 on people in Scotland with diabetes and a range of other health conditions. And we'll be guided by evidence from that in assessing any continued risk from the virus. But I'd absolutely encourage anyone who has any concerns about their diabetes or any other condition and COVID-19 to contact the GP or the diabetes clinical team, and they're best placed to provide specific advice and support to the person.
David Stewart.
Thank you, Presiding Officer. Research by NHS England a few weeks ago concluded that 1 in 4 coronavirus deaths in hospitals are people who have diabetes.
We seem to have a problem with David Stewart.
Shall I have a go at
have a go and we'll get it on the record. Yeah.
So NRS, National Records Scotland, published some data on the 22nd of May as an ad hoc, which I hope folk would find useful, and that showed that in Scotland 15% of all COVID-19 cases also had diabetes mentioned on the death certificate, also COVID-19 in the death certificate. So I guess we're still learning about this virus, but it is really important that we record all of that data, and obviously the Scottish Government and NRS will publish that data as it becomes available. I hope that's roughly what the member was looking for.
Well, let's hope so. Thank you very much. And that concludes Portfolio Questions on Health and Sport. As I say, apologies to both Emma Harper and John Mason for being unable to reach them. And this meeting is suspended until 3 o'clock.